tout le monde, donc merci d'être venu. C'est notre première conférence scientifique après les vacances. Merci Dr Lebouché. Je vais vous présenter brièvement. Donc, Dr Lebouché is an associate professor in the Department of Family Medicine here at McGill University and also a clinician scientist at DRI MUHC. Dr Lebouché's research interest focuses on how to improve HIV care and prevention using prompts and connected medicine and AI-based chatbots, particularly by meaningfully involving patients in research. Dr. Lebouché also holds a strategy for patient-oriented research chair in innovative clinical trials granted by CIHR. He's also a recipient of the 2023 CIHR CAN for Excellence in HIV Research Award in Clinical Science for Canada. And I also know that you brought your postdoc fellow online.
Yeah.
Right? Dr. Ma, welcome. And
Hello.
Dr. Ma is also a fellow in the Department of Family Medicine here at McGill University and also at the RIM UHC. And Dr. Ma's research interest focuses on the intersection of AI agents and healthcare with a desire to develop human-centered technology. Thank you very much for coming.
Thank you for the invitation. Bonjour à toutes et à tous. I'm the director for the Clinician Scientist program in family medicine. And I think last year you had two famous residents, Dia Shalati and Katy Novinsky, who did part of their clinical 20% here. So I'm very happy to be here with Yuanchao today and to present. I will only present what we're doing around the chatbot. So here I put my disclosure. And I want to acknowledge the FRQS, the FRQ support, which is very important. And we are not a lot of clinician scientists, family physicians supported by the FRQ. So I think it's important and we need more. It's part also of the objective for the CSP program is to have more clinician scientists, family physicians. We can develop research in family, practice for family physicians. So that's really important. So this is my part of my research team. So the research program I tried since 2013 to develop is really to try to co-develop, to combine, to implement like responsible, scalable digital health innovation. So in artificial intelligence, mobile health, and e-prompts for patient-reported outcome measure. And really the idea is to empower particularly people living with HIV, as it's a chronic condition, and to assist also providers and to try to modernize our model of care so they can be more equitable and more patient-centered. And really what we're doing is mainly for HIV, but also because I'm HIV physician at the Chronic Virus Services at the Glen, and also for Hep C and for other sexual transmitted infections. So really I focus mainly on, with my team, we focus mainly on HIV, but actually we are working also in cancer with Sylvie and also in pediatry with Esli Osman Liu. So we try to develop our product in other. So really, what we want to develop today is what are the key considerations when we want to design, to develop, to implement a chatbot to support the self-management of people living with HIV and to see what it means and what are the consequences in real-world care settings. So really, the research area is HIV infection. So HIV infection, what does it mean? It means that we have still 41 million of people living with HIV all over the world. And also that in Canada and in Quebec, the epidemic is not controlled. In 2022, 2023, we have an increase around 35% of new cases. And it's one of the biggest increase all over the world, more than some countries in Africa. Most of them, it's because of migration, because we have received a lot of migrants, and some of them are living with HIV, or most of the time, they will acquire HIV when they arrive, particularly in Montreal. So that's something very important. So actually, we have 400 new patients in our clinic each year. So it's an increase of 20%. And for sure, we don't have an increase of 20% of our healthcare provider. So we have to adapt the model of care and possibly to decrease sometimes our service to be able to answer to everyone. Also, antiretroviral therapy change a lot of things. Actually, it's a chronic condition thanks to this antiretroviral therapy. So it's difficult to die because of HIV, except if you are diagnosed too late or if you don't take your treatment. Otherwise, what is interesting is actually, in 1995, for a young woman, 20 years old, life expectancy was 8 years. And actually, at 20 years old, the life expectancy is 60 years. So possibly the life expectancy is bigger than the non-HIV population because they have a chronic follow-up. So what is interesting, when you come in the chronic condition paradigm, it means that the boss is the patient. Because I see my patient every year. So we see the nurse possibly every year. So for the rest of the year, they will be alone with their question, with a changing life, sometimes a chaotic life also. So that's why it could be interesting to give them access to verified information, to personalized tools, to support their daily management. That's why we develop prompts. That's why also we develop the chatbot to give them so they have access to this verified information 24 hours a day, 7 days a week. So that's what we developed in 2020. So just before the COVID pandemic, we developed this AI-based chatbot. So really the idea at the beginning was to provide timely, expert-validated information on HIV self-management. And also we covered actually more than 100 HIV self-management related topics. It could be, I have to travel because of jet lag. When do I have to take my antiretroviral therapy? What kind of vaccination or immunization I can do? Undetectable mean untransmittable. How can I deal with that inside with my partners? So it's things like that, okay? They can find. And it was developed with patient, with healthcare provider, and with researcher. So 2020 is our starting point. Yuanchao, it's your turn.
Yes, yeah. So that's why, yeah, thanks for Bertrand's introduction. And then with all the backgrounds, we have this idea to look for, let's say, interesting tool, and we found chatbots, which is a combination, let's say, combination of the AI techniques and then natural language processing techniques. For those who are not familiar with natural language processing, so mostly is how we treat free text as input, and then generate output based on these free text. And there is several technical turning points. One of the most important is the ChatGPT in 2022. I guess most in the room or online are familiar with that. Everybody's probably somehow using it. And this introduced, let's say, the chatbot, make this concept super familiar to the general public. But chatbot is not only AI and natural language processing, but it can also use other techniques, machine learning, deep learning, even large language models. In 2024, we have a lot of, let's say, large language models coming out by different companies. All those are powerful. Next slide, please, Bertrand. Yeah, and for us, we did a quick literature review 2 years ago. It was published last year, and what we try to see is how chatbot is being used in healthcare, and at what role, what are the users, what are the benefits and limitations. And what we found is that chatbots usually are seen as virtual assistant, and usually we use it to deliver healthcare services, give patient support, care management, educations, and also another part mostly focus on providing administrative assistance to healthcare provider to ease the burden and also improve, let's say, the efficiency of the system. So based on the first aim, we can see that chatbots are quite promising in promoting self-management of patients because we can give different services and different information. Next slide. And yeah, in this project, our, let's say, objective was to design and develop a chatbot to support self-management among people with HIV. And we focus on the use of also a participatory design approach. Next slide. Well, the subject objectives, we'll dive into it afterwards. And then participatory design, next slide, is where we engage end users into the whole process of development of the tool, and we make decision with them. What we found interestingly is that in the literature, we did a quick literature review on HIV care-related chatbots, and less than 40 involved end users in the development. And this limited involvement leads to usability gaps, and that's why, next slide, in our project, we lead, let's say, we establish a design committee with a multidisciplinary, let's say, collaborators from developers to doctors, pharmacists, and researchers, and most importantly, people with HIV with us, and to deliver this patient-centered product. Every 2 to 3 months, we stick together, workshops, 60 minutes. We try to work together on one specific task, and time by time, we deliver an end product. And all these members can be reached out easily during the whole process. Next slide. And afterwards is the digital health intervention life cycle, which what we see a lot of AI models being developed during the last several years, but their implementation in the real settings is lacking, and we need kind of a systematic ways to do it. So that's why we follow this needs assessment, design and development, and then third step is to plan for implementation. Afterwards, evaluation of the implementation, and most importantly is keep iterate on this cycle to conduct our projects. Next slide. Lastly is about the responsible AI framework. It's because when we do let's say, AI projects, it is not only about performance. We heard a lot about AI can do A, B, C, D, E, like different tasks, or even passing humans. But most importantly is also the ethical consideration for the best practices when we try to implement the tool into the real world settings, especially in healthcare sectors. That's why we follow this shifter framework. Next slide. Yeah, next one. So first is about the sustainable AI. How we show it is we need to constantly, let's say, lead the project with a constant leadership and to ensure, let's say, the project viability in the long term. For example, is we need update the chatbot time by time, keep updating it to ensure its relevance, and then to make sure that people could use the most recent technology and also avoid problems with, let's say, in the maintenance. And then we need to also assess the social, economical, and environmental impact of the development on human well-being. We need to always clarify that the role is to assist healthcare, to augment healthcare system, and to ensure that the trust is being kept, or we still build the trust between the AI tools and the healthcare system, but also between the AI tools with its users. And afterwards, we need to also make sure that the tool is inclusive. As we said, patient and stakeholders' perspective needs to be considered, but also we need to tailor the whole intervention to the cultural background and then linguistic requirements. And on the fairness side, data is important. A lot of AI tools are being trained with historical data. There's problem here and there. So when we try to build a such tool, we need to ensure that it reduce the healthcare or help reduce the healthcare disparities across groups with the new tool, but not creating new gaps. And then finally, transparency. We need to keep everything open with the data privacy parts, security protocol, informed consent before using, and also the model interpretability is important. Let's say technically, why the model is making errors, what are the problems, and then clearly, let's say, communicate these limitations to the audience. Next slide. So yeah, with all this in mind, in 3 years ago, we did a master protocol, which is we can see as a methodological framework to show how to, let's say, deliver or design, co-develop chatbot intervention with patient partnerships and also with different stakeholders. And it serves as blueprint for us to achieve several studies. The objective, so there's 4 different objectives in this master protocol. One is co-construct different versions of the chatbot depending on the needs. And then when we have a fixed prototype for each, let's say, context, we assess the usability with a small sample. If positive outcomes, we enter for translational research purposes to measure implementation with a larger sample. If negative outcomes, we just reiterate the prototype and then redo the usability study. Continuous improvement is important, and at the same time, we need to evaluate patient and stakeholders' inputs throughout the process. What's the impact on the final product? That's also important to be understood. So this is set as objective 4. Next slide. Yeah, as Bertrand said, this chatbot that we deliver, let's say this serves as a case study for the whole master protocol. And the first one is for HIV that we delivered guidance. It can work 24 hours, 7 days on Facebook Messenger, provides guidance on antiretroviral therapy and also ART management when traveling. These 2 topics have been decided at first with the patient committees, and then we add common HIV-related knowledge, vaccination recommendations, modes of transmission, especially COVID vaccine, if they can take or not at that time, to answer patients, let's say, questions at the second iteration. And then it also supports both English and French, so it can speak in 2 languages, the chatbot. Next slide. Okay, so here is kind of how the technical part function. First of all, Bertrand, you can click and click. First of all is the message. I forgot to take my pills today. What should I do now? This is, for example, we received this message to the natural language understanding, let's say, module, which we trained with different data that we collected from our patient committee, and then we train it to like let the model understand what are the different meanings after these messages. Next one is, for example, it can understand the intention behind these messages, but also next click. The intention behind the slide and also the important information to be extracted. For example, here is late for medication, and then we can extract the medication name, for example. But here in this example, next, is there is no medication name. So what we see is entity equal to none. And then afterwards, all these information enter to the second module, dialogue management, which is being trained with different decision trees that we collected from healthcare professionals and then trained it with it. Next. So the model could understand what decision to make at this stage, and then what's the next action to be taken. Next. Next. Yeah, so here we also added different mechanisms. For example, if it doesn't understand, it will reconfirm the intention. Please rephrase your last message. If after 3 times, it would just say, please contact a healthcare professional. So the bot is here, but it's not able to answer this question. So we need human interventions here to help. Next. And here it's indeed the action to be taken is ask medications, and afterwards generate the response, or the response are being, let's say, edited or validated by the healthcare professional team, and also we trained from a validated database. Next. So here the output message is for what's medication, because we don't know about which medication is here, so we cannot give, let's say, the appropriate answer. And here's another demonstration. Just click. So here, how are you? I'm great, thank you. Can I ask you a question? Feel free. This is the version that we use to deliver the usability study. What does undetectable mean? It means few copies of the virus in your blood. Why you're asking this? Are you concerned about your health status? Not really. Good to know. Further explanation. Thanks. You're welcome. And a second question, I have a pill, but I don't know what it is. What are the letters and numbers written on the pill? 227. Good. This one is eccentric. Picture to confirm. Does it look like this? Yes. Thanks. My pleasure. So this is how it covers with Marvin, quite straightforward, easy to use. And with this product in mind, we afterwards enter to the usability. But next slide. With this, in this master protocol, we also explain, for example, how the data being managed, or the servers are located in Canada, being compliant with the regulations, all the communications are being encrypted. And also we have established governance board where we invite different experts from different fields of AI. We meet together and then gain their external perspectives on the project to ensure the responsible development. Next one. With this protocol, we arrived with 4 different versions: MARVIN for HIV, and then MARVIN Pharma to support community pharmacists treating people living with HIV, and then MARVINA for breast cancer, and then MARVIN Champ for pediatrics. And both versions are now being prototyped, and we end the needs assessment and first quickly start a trial afterwards. Next slide. So the key takeaways here, I think it's the first master protocol, yeah. Guide to develop the chatbot, but most importantly, limitation is that it took 1 year from elaboration to, let's say, the institutional ethics approval, but also it helped us, let's say, gain 4 years for 4 different studies afterwards, because all the studies are being englobed under this protocol. So at the same time, it serves as a strength. And then the usability study, we conduct this study to assess the real-world feasibility and the usability. It adopt the mixed method design. Quantitatively, we use validated questionnaires to measure the usability and acceptability. Qualitatively, interviews through technology acceptance model, where we could understand better how usability being, let's say, addressed. And then we also triangulate the results with consultative framework for implementation research. Next slide. And the results, so we did the study in 2021 to 2022, April to April, and then at McGill University Health Center. Most importantly, sample size equal to 28, but only 5 have been self-identified as women. English and French quite equal, mean age 40.2, mean years diagnosed with HIV 8.2. Most claimed moderate experience with health apps, and the majority are comfortable with mobile phones and then Facebook. Next slide. For the results, so we validated, or we confirmed the global usability with both quantitative measures. Its mean scores past the thresholds. And then there's no significant differences between English and French. Qualitatively, 12 facilitators and then 10 barriers to the global usability. But overall, it's been said from our, let's say, participants that Marvin is a good reference. Instead of seeing someone or waiting for a doctor's appointment, they can get reliable information, and it's a go-to tool for them. Next slide. So yeah, this kind of ends, let's say, the two studies, and until now, MARVIN has been, let's say, developed as a long-term chatbots, long-term focused chatbots to resolve some tasks regarding ART adherence, but also deliver some information to support their self-management. And we've been integrating different techniques and different algorithms to support not only text understanding, but also help decision making. It can do also some calculations, etc. And it supports two-way communications, so in a reciprocal way. Here also we didn't, let's say, present a triage model, but we also developed a triage model that could help identify adherence of antiretroviral therapy, let's say the barriers and risks. Next slide. For the responsible AI part, so sustainable is important as we see well the last 5 years as a team we collaborate and co-lead this project and keep updating, developing different parts, doing let's say the trial real world. So this shows the leadership of the project sustainability, and then human-centeredness. Also, we emphasize that the chatbot is assisting but not replacing the healthcare provider to augment, let's say, the whole system. It supports the self-management. We also re-identify the appropriate use with the usability study, and then the last triage model that we didn't present here, but it quite enable a first layer triage support to the whole system. We also co-design the chatbot through the entire process with all the stakeholders and people with HIV. It's supported in both languages, English and French. And next slide. So it all shows the inclusivity part, and then for fairness part, the whole product we aim to let's say deliver or increase the healthcare access, the health information access to all people with HIV, and all the training data being validated, let's say with the committee, and we keep communicate the results with the whole community. And also disclose the privacy policy. All this is about the transparent part. Next slide.
Just to add, I think this framework is very important because we have still the beginning a question, We started possibly before OpenAI, but for the whole project, we had possibly $200,000. OpenAI, they have billions of dollars. So what is our place, as an academic research group, why you are doing that? And I think it's possibly this framework is very important because what we're doing is very different. We develop with patients, we develop with users. And most of the time, OpenAI or other Google, they develop something, oh, it's marvelous, it's incredible, use it and adapt it. Okay? You have to be adapted to ChatGPT because ChatGPT was not really developed with users. So that's why I think we push a bit on this aspect because our question is still a question, what is our place as a small group to develop things? And at the end, we have the only academic group to develop something like that internationally in HIV care. So that's why it's something important, and it could be after part of the discussion, what is the place for academic research group in this, in the AI product? You can continue, Yuanchao.
Yeah. So as Bertrand's saying, one of, let's say, the challenge of the whole project for the next phase is on a long-term sustainable model, because we focus on an open source, let's say, strategy. All the models are being local deployable, and it shows the affordability and the feasibility in, let's say, hospitals or local care systems, but there is a challenge of scaling as our team is, let's say, with limited resources, human resources, but also hardware resources, and all the competition with all the big names. We need to find kind of a sustainable model for the future, let's say, development. And yeah, this is to be discussed. And then afterwards, we also follow a modular AI strategy. What we try to follow for the next phases is that we build small language models, but that are powerful and efficient in terms of, let's say, training resources or cost, everything. And it's also could help with the interpretability, and it's also more scalable as a solution. And what we are doing right now is, for example, stigma and motion detection modules, but also different small modules like data anonymization, multilingual translation, memories, etc. Next slide. Yeah.
So
next slide.
just to explain, so I asked Yuanchao to present because Yuanchao, was his PhD, what we presented, and he led this project since the beginning with me, and he presented last Friday his defense for his PhD, and it was amazing, really. That's why now he's a PhD and he's postdoc. So it's really a student-led project since the beginning, and at the same time they train me on AI, and they continue to train me on AI and to train my colleague. And I will present also in this module development model what another student, Sébastien, is in the first year as a master student engineer, and a few 2 months after he started his master, he sent an abstract to CROI with the HIV conference. It's the biggest conference in HIV, and he was accepted as an oral. So the middle age in this conference is around 50, and he was 22. So it was very interesting, and he correct also this big cheese in HIV. So it was very interesting. So really, and he was also invited for the IAS conference, International AIDS Conference in Kigali during the last summer to continue to present his project. So really the idea is to use our chatbot to detect some emotion. So that's why it's a development, evaluation, AI-based MARVIN chatbot for the mental health management module. Because the problem we have that when they discuss, when our patients discuss with the chatbot, they have also their own emotion. And we know that people living with HIV, 30% they have depression, almost the same anxiety, and around 50% they experience stigma. Even after the huge improvement in HIV care, they continue to have the same problem, almost the same problem since the beginning. So if someone explains to the chatbot, I want to kill myself, the chatbot was unable to understand what happens. So that's why we developed, and it was really the Yuanchao and Sébastien idea to develop this module. So what we did, we will not use right away some patient with mental health issue. So we use database. So they find some database with insult. You can find a lot of things on the internet, self-harm, and also we use a lot of our data we have. So, like an insult, you have just a clueless as people will discriminate against me, self-harm. I just want to be free. I don't want to be this depressed drain on everyone around me anymore. So they have all this sentence or this data, and we develop the module and we test with this data to be sure if it's well classified. So you remember, so it's a mixture of model. What does it mean? It means that our chatbot can actually understand 150 conversations. So we use ChatGPT or other LLM, so other chatbot as slave, because they have a lot of potentiality we don't have with our chatbot. So we can do like a mixture of model. We don't share any sensitive data to them. We just, our chatbot, MARVIN, ask the ChatGPT or other LLM to do some task. Okay, that's what we did. So if we send to the model an insult toward people living with HIV, with a natural language understanding, it will understand the different word, the plus of each word in the sentence, and also the background. And with that, it will see in the dialogue management, it will understand it's an insult, language is English, and there is actually one response possible if you have this kind of intent, kind of insult. So it will take in the response selection some data, and after It will answer as an AI SQL chatbot. They understand that sometimes people express themselves strongly, everything, and it will also send the phone number for the suicidal, aid line to be sure that the patient, the user, can have the right information. So the chatbot will not do any diagnosis. Even it can do diagnosis because I don't want to finish in jail, okay? Because for illegal medical exercise, so I don't want that. But he can do it. Of course, he will be able to, but we don't do it. He recognizes and he sends some information for help. And all they take the 3,000 sentence database, they put a sticker on each sentence, if it's self-harm, insult, or normal. And after they put this 3,000 in the model, and they check with sensitivity and accuracy, and we see we have data. It was more than 95, 97. The model classify accordingly each kind of sentence, if it's an self-harm, insult, or normal. So you can see here what it means. So I want to end it all. And now the chatbot is able to detect this, and he can send the hotline number. And also after, he will be able even to ask the patient again how he feels today, everything. So it's something we can do. For the next step, Sébastien actually tried to detect other emotion. So anxiety, everything. So to see if we can do better. Alors, what is interesting, it was the chatbot can't detect sarcasm. So if you say, believe me, I'm not insulting you, I'm only describing you, it will detect this as a normal message. And if you say managing HIV is super cheap, you're just a never-ending quest for meds, paperwork, and people still don't get it, totally effortless, it will understand that it's an insult. So that's interesting, and we will have trouble with that. You can be sarcastic with a chatbot, actually. So also what we develop is something we are developing also with Sylvie, is MARVIN. So it's he's a resident, Max, is a resident in internal medicine. With MARVIN, is AI chatbot. Oh, and you continue, Yuanchao, sorry. It's for you.
Yeah, it's okay. No, it's okay. Yeah, the MARVIN chatbot. So the MARVIN chatbot is we developed to try to support self-management also for people with breast cancer. But at the first time, as Sebastian developed this, let's say, mental health problem detection module, we quickly adapted to the breast cancer care, let's say, settings, as also emotional distress affects 40% cancer patients, but let's say undetected in the oncology clinics, and then we do this following. Also, I think we collected messages online and also real world. All these we use it as training resources to train this module. Also, we tagged again with different emotion tones, very negative, normal to positive for different tones. And then the model afterwards, all the training procedure is similar to the previous module being presented, and the model performance sensitivity this time is around 84 to 86%, and then positive predictive value is 79 to 91% across different, let's say, tones categories. And then what we're trying to deliver is afterwards we will flag the negative emotions and then ask the nurse to intervene if needed. And then possible impacts that we see is it could support early distress detections to deliver, again, timely and personalized care. And the next step is, as we said, pilot testing with real patients in the clinics. And it's also accepted at ESMO on this year for the conference and our oral presentation. Next slide. Another discussion is, we want to understand this, as MARVIN has been locally, let's say, approved for the usability. For the next step is we want to assess it worldwidely in different settings to see its generalizability. For example, we have a project in Ghana, and then we are planning, and then we are also planning a project in Canada and Europe to see if we could use it to support HIV care linkage.
So yeah, so just to finish, so two things we will try to do is particularly I told you actually we have a huge increase of new HIV diagnosis, particularly in Quebec, but also in Europe, they have some similar trends actually because of migration. And we receive, particularly in Quebec and in Vancouver, also a lot of men who have sex with men. They came from their own country where homosexuality, gay contacts are very criminalized, and they arrive in Montreal where everything is possible. So a lot of them are suddenly very vulnerable to HIV. So what we wanted to do is to put some QR code, even in the airport, everything, where we can find this MSM population, migrants. And so when they use the QR code, they will be linked to the chatbot. The chatbot can discuss with them. The chatbot, and particularly because the chatbot is stigma-free. Is very woke even. A chatbot is woke by definition, so it can avoid every stigmatizing language. The chatbot is not gay, is not straight, so it's perfect for this population. And we want to do an evaluation if they are HIV infected, so we can link them to HIV care, or if they are vulnerable to HIV, we can link them for pre-exposure prophylaxis. And with the new PrEP we have actually, we will have next year PrEP every 6 months injectable subcutaneous, so it's just 2 injections per year. There is a very interesting thing to try to protect this population. So with the chatbot, we will link them with HIV care or PrEP clinic after that. So that's what we are developing actually that's our new project. So it will be Vancouver, Montreal, and also in Munich, in Germany. And after, the idea is to use it in several cities all over Europe, and to try to see in a large scale this an implementation of the chatbot. And the other thing also is one of my postdoc student, Abdul, he just finished his PhD in family medicine, and he's from Ghana, and he worked to try to improve HIV prevention and STI prevention for young women who are particularly vulnerable to HIV in Ghana. And the problem they have is most of the time, all healthcare providers are very stigmatizing language. So we know that. And even here, it's very difficult for that. So with the chatbot, they can find like a safe virtual space to discuss, and why not to be linked with PrEP or to be linked with other help to try to stay secure and to try to avoid some STI. So it's like a parallel project we want to develop. So key takeaways, so it's interesting because really the chatbot can be like a digital coworker, because actually when you want to develop something, even in HIV prevention, you will need new nurse, you will need new social worker, you will need new doctor, everything, and we don't have this new healthcare provider. But the chatbot can do things without new healthcare provider, can do some tasks, and so the healthcare provider can focus on more interesting tasks. So they don't have to do the evaluation of the HIV risk for 30 minutes, because it will be done by the chatbot. So, and then the chatbot can give the information after. So we don't need more healthcare provider, and we can also help the healthcare provider to focus on the most valuable task they can provide. So that's why it could be interesting. Of course, we have only the question of responsible AI, so to be sure. So that's why also we are developing, because we want for the MSM project that they can discuss in their own language. So that's why we need this module. We need the memory module also, because if we discuss with the chatbot and one day after you continue to discuss, the chatbot forget everything, it will be crazy. You need someone who memorize what we discussed before. So that's why also we have to develop all this model. And for the our last slide for the discussion, the impact. Yuanchao, you can finish.
Yeah, I can. Yeah. The project started in 2020, and we gained very quick attention, and afterwards, different, let's say, yeah, you go too fast, but different impacts, let's say, on different like social wise or like university level and also scientific level, we kind of gained an attention with this project. Next slide. It's was the yeah, with the usability study afterwards, we gain a lot of attention also from the whole general public. We also been spotted, let's say, on a random YouTube video to talk about how HIV, how AI is quietly transforming HIV care globally, and we've been mentioned there and here. And also recently, the work has been highlighted. Next slide and next slide. In the IS, like Bertrand said, we've been also mentioned in one Lancet HIV, let's say, Commons, reimagining HIV care. But most importantly is from our patients, the impacts that we see is when a patient participant 15 in middle-aged woman says, I know that's a long time of money research, but every year maybe just keep improving him. So that whoever is using him knows no matter what, they might have not have access to Dr. Lebouché or whichever doctor, but because of Marvin, I will be able to solve my issue no matter where I am. Whatever Marvin will answer me might make me come up with a solution as I wait for treatment. That's how I look at it. I feel Marvin shouldn't just be limited. So this is kind of motivates, let's say, the whole team. We want to keep invest ourselves to build this project in a responsible way because we see the impacts on patients. Next, I think that's it. Yeah, the journey is far from over. It's just started.
Thank you for your attention.
Thank you.